Hello, esteemed moderators Alisa Rodionovna, Елизавета Vladimirovna, Mikhail Andreevich. The topic of my presentation is dedicated to the study of gait in patients with lower limb prostheses, especially how the method of gait cycle detection affects the patient's kinematic profile. Why is this important? This study compares the manual method with the method involving multiple force plates. When performing functional gait analysis in patients with pathological gait patterns, such as children with cerebral palsy or patients with lower limb amputations, it is not recommended to use automatic gait cycle detection. This is because the foot often either contacts the ground with the entire sole instead of heel, or the patient is unable to place one foot on a single force plate, leading to incorrect data interpretation. But how accurately can an operator, a video analysis specialist, identify these fault contacts using a marker-based motion capture system? Inaccurate gait cycle detection can affect the entire kinematic and kinetic analysis of the patient. The study aims precisely to evaluate that accuracy. Let me briefly explain the marker-based motion capture system. The laboratory is equipped with 6 high-speed infrared cameras, Micus M5 by Qualisys, 2 video cameras from the same company, a set of passive reflective markers, 2 Kistler force plate, and a set of Delsys electromyography sensors. Research in the lab spans various areas, from robotics to the use of virtual reality for physical therapy. Additionally, Peloton and prosthetic designs are tested here, and gait studies of children with cerebral palsy are conducted. Passive markers are attached according to a specific placement scheme, which has been validated on a large number of patients, especially in Russia at the Ilizarov Center, where over 1,000 children with cerebral palsy were tested using this scheme. It was developed in Italy at the Hospital of St. Olga, based on anatomical landmarks such as spinos, processus of bones, and joint articulations. After the passive markers are placed on the patient's body, the cameras detect them as undefined artifacts, and our task as motion analysis specialists is not only to create a digital twin of the patient, but also to reconstruct lost trajectories. In the video, you can see a patient walking in one of 3 developed prosthetic designs, and the blue lines represent the ground reaction force vectors. This slide shows the gait cycle, which begins with the heel strike and ends with the next heel strike of the same foot. There is also the moment of toe-off, loss of foot contact with the ground, which is another important indicator used in the manual gait cycle identification method. We distinguish between double support and single support phases. The double support phase is when both feet are in contact with the ground, and the single support phase when one leg supports the body while the other is in swing phase. Aims of the study: first, identify whether there are any numerical differences in joint angle measurement during the gait cycle when using the manual mode of gait cycle identification versus the multiple force plates methods. Secondly, if differences exist, evaluate the discrepancies between the 2 methods using statistical analysis. Third, identify visual differences and interpretation of goniograms in the patient's gait cycle when applying manual methods and multiple force plate method. The manual mode is primarily used when studying the gait of individuals with cerebral palsy or pronounced pathological gait. For example, they miss their force plates, walk unevenly, or have steps of varying length and width. In this image, the patient is represented as a cloud of points, and the ground reaction force is shown as a red vertical arrow. At the bottom, manually set Gait cycle detection are displayed, such as foot contact with the ground, toe-off contact with the force plate, and toe-off from the plate, shown separately for the left and right leg. With automatic gait cycle detection, everything is straightforward. The system records foot contact when the patient steps on the force plate and toe-off when the foot lifts off. But how does the operator manually identify gait cycles? What does the operator focus on? In this image, you can see marker detection frames from Qualisys cameras which the operator uses to determine contact events such as heel strike. By moving to the next frame where contact occurs, the operator can pinpoint the movement of contact since the system captures at 330 frames per second while the force plates operate at 1000 Hz. We also have Qualisys video cameras which can also be used to identify gait cycles. They're captured at 180 frames per second, half the speed of the Micus M5 cameras. However, detecting the exact moment of heel contact becomes more difficult. As shown in the image, there is no visible change across through consecutive frames. Let's summarize the information. In manual gait cycle identification, the operator must determine foot contact, toe-off, platform contact, and platform toe-off for each leg. In contrast, when using the multiple force plates method, the system only records the initial and final heel contact events, and only while the patient is stepping on the plates, which record at 1000 Hz, even though steps occur before and after plate contact. In this study, the patient wears 3 different prosthetic designs. The patient's gait index corresponded to normal gait. Each prosthesis is tested across 5 walking trials, analyzing 4 segments on both the left and right side. In total, 120% are analyzed. To determine the statistical significance between the two methods, a two-sample t-test with unequal variances was used. A significant level of p less than 0.05 was set to assess whether the differences in joint angle measurements were statistically significant. The analysis focused on pelvis tilt, hip flexion extension, and knee and ankle joints. Here, 3 tables present the statistical analysis results for kinematic parameters with different prostheses. Both the right and left side were analyzed. Each prosthesis was tested over 5 walking trials. For each parameter, the p-value and t-statistics were calculated. In some cases, manually defined gait cycles led to discrepancies in joint kinematics, indicating significant differences in gait measurements when comparing the two methods across different prosthetic trials. The statistical analysis revealed significant differences in pelvis tilt and ankle dorsiflexion, as confirmed by p-values below the threshold of significance. These differences, which varied in direction depending on the conduction, highlight the variability introduced by different gait event detection methods. Regarding visual differences, we can also observe discrepancies. For example, pelvis tilt in prosthesis 3rd trial, 2nd, comparing the manual methods and the multiple force plate methods. The difference in pelvic flexion angles in the sagittal plane on the right side at 8% of gait cycle is 1 and 6 degrees, and at 67% is 1 degree. At 67% of gait cycle, which is during the acceleration phase, the difference is in 2 and 5 degrees on the right side and 1 degree on the left. These variations affect the interpretation and analysis of the patient's kinematics graphs by the motion analysis specialists and can lead to discrepancies when presenting functional findings to medical professionals. This study revealed significant differences in the patient's kinematics profile when comparing the manual methods and the multiple force plate method in trials with different prostheses. Statistical analysis confirmed the presence of significant discrepancies, especially in pelvic tilt and ankle dorsiflexion, supported by p-values below the significant threshold. Considering that the patient's gait with the prosthesis was relatively normal, allowing for clear detection of ground contact, an important next step will be to conduct a separate study assessing discrepancies in patients with pathological gait patterns such as children with cerebral palsy.